Hello, everyone. Welcome to BrainMap. And welcome to our new season, the first talk of our new season this fall. This seminar series is co-sponsored by the P41-funded Center for Mesoscale Mapping, housed in Martinos Center. Today, it's my great pleasure to introduce our speaker, Dr. Esther Warnert. Trained as a medical engineer, Esther Warnert focuses on bridging the gap between new developments in and clinical applications of the physiological MRI techniques. Dr. Warnert started her research career with the development of novel vascular biomarkers based on arietal spin labeling MRI during her PhD research in the group of Professor Richard Weiss at Cardiff University in the UK. Since 2017, she has worked at Erasmus Medical Center, where she started as a postdoctoral researcher in the group of applied physiological MRI of Professor Marion Smith, with the development and application of advanced imaging techniques for assessing protein buildup and vascular physiology in glioma. It's starting and fostering multidisciplinary local and international collaborations, including funding the European Network Glioma MR Imaging 2.5, of which she is currently the chair. She works on generating impact of advanced MRI techniques in clinical practice. As principal investigator of Bench-to-bedside MRI imaging biomarkers, she is driven by solving problems in clinical diagnostics with innovative approaches to image cerebral physiology in health and disease. Her research group works on the development and validation of physiological MRI techniques for application in population-based imaging and imaging diagnostics of patients diagnosed with brain tumors and stroke. I would just like to remind the audience, please address questions using the Q&A box or raise their hands at the end of the talk. Dr. Warnert, thank you very much for coming today for our first seminar of the season. Virtual stage is yours.
Yeah, that was a brilliant introduction. Thanks very much. And thanks very much for having me giving this seminar. I'm really honored, even that I'm kickstarting your new seminar series. So, I mean, it also means that, you know, I don't have big shoes to fill from last week, although I have been told that you have had quite some few nice speakers. I did also prepare a few slides to introduce myself, but maybe I'll skip them really quickly because I think that was a really nice summary that Esther just gave. I'm going to talk to you about mainly about the imaging for tumor environment mapping study. And one thing is that there's quite a lot of information in there. And I do know we have questions at the end, but also feel free to interrupt. And I think so I'll keep a slide eye out on the Zoom, but I know that Esther will also stop me if you have any questions in between. So do feel free to ask those. Right. So yeah, as Esther already mentioned, I'm trained as a medical engineer. So I did that at the Technical University of Eindhoven. So I'm Dutch, so a little bit of geography. Eindhoven is in the southeast of the Netherlands. Had a really nice time doing my graduate degree there, my undergraduate degree. I indeed went to Kubrick with Professor Richard Weiss. So that's in Cardiff, which is the capital of Wales. They're always very tough. They were always very tough at reminding me it's certainly not England. Where I did my PhD on the development of perfusion MRI techniques, mainly based on arterial spin labeling. And indeed, I was very, very happy in 2017, where I could join the group of Professor Marion Smith. I know she's also given a talk last year, so hopefully not too much overlap. And now I work at the Erasmus Medical Center. So that is the largest academic hospital in the Netherlands. We have around 1,200 beds. And we have a really nice department of radiology and nuclear medicine. So if you ever have the chance to come over and visit. And since 2019, also thanks to the brilliant mentoring of Marion, I became an assistant professor where I indeed focus on sort of bridging the gap between research and the clinics. Of course, we can do a lot of cool things on the research end, but is all the cool stuff necessary in the clinic, and the other way around? Maybe there is a clinical question that we really need an answer to, and then we really need all the cool stuff perhaps. So that's what I try to do with my research line on bench-to-bedside MR imaging biomarkers. And for that, indeed, I collaborate with the Stroke Center, so the population-based imaging. So that's the Ergo, or the Ergo Center, that focuses on the large Rotterdam, the Rotterdam study, which is the population-based study. But of course, I also collaborate quite a lot with the Erasmus MC Cancer Institute. And most of my talk, I guess, is really focused around that work. So what I would like to do in the next, 40-ish minutes or so is really talk about brain tumors, about glioma. And what I'll do is go through some of the developments that we're doing and some of the validation of those techniques within the item study. I briefly also want to touch upon some of our beyond item work, so some of the work towards clinical application that we're already looking into. But also I want to talk to you about GLIMMER, or glioma MR imaging 2.0. So lots of information for you there. Stay with me. So for those of you, so glioma that don't know, the glioma is a type of brain tumor. In the Netherlands, we have around 1,200 patients a year that are newly diagnosed with this disease. In the US, I think it's about, it's well over 80,000. It is a type of brain tumor that comprises 25% of the primary brain and central nervous system tumors. And one of the things that we often discuss is that we look at enhancing and non-enhancing tumors. So what do these look like on MR images? Well, here on the left-hand side, you see an example of a non-enhancing or a diffuse glioma. It simply means that if we inject a contrast agent, so as you can see here on the left-hand side, there is actually no contrast agent that leaks out of the vasculature into the tissue, just into the tumor tissue. As you can see, they're hyper intense on T2 weighted imaging. And this is also the case if we look at a very aggressive type of brain tumor, which is a glioblastoma. Although what you can see here is that the glioblastomas quite often, or almost all of the time, they will enhance. And that simply means after T1 weighted contrast, after injecting contrast agent, you will see an enhancing ring there in the brain tumor tissue. So historically, histology was the cornerstone of classification of these type of brain tumors. As you can see, up until 2007, the World Health Organization classification scheme, these type of tumors were divided into 4 groups, but they're all sort of based on histological features. So always a biopsy, of course, is needed. Now this, one of the problems that arose here is that if we look at those grade 2 and 3, slowly moving towards more aggressive tumors, what we actually saw in this classification, that first of all, it was difficult to have consistent grading based on the histology, could be quite heterogeneous. And then the distinction between these 2 groups, in particular grade 2 and 3, in particular when they were non-enhancing gliomas, was not that great in terms of overall survival. So we now already know that we can improve upon this by including molecular biomarkers. And this has tremendously improved treatment management, but also the general understanding, of course, of gliomas or brain tumors. So here an example of the exact same patient group, but then with the updated World Health Organization classification of 2016. Now biological or molecular markers are taken into account in this diagnosis, and you can already see that in the same group of grade 2 and 3 type of gliomas, we see 3 distinct groups emerging. And only recently in the update in 2021, this has even been further refined, but it only has meant that those molecular biomarkers have become ever more important to make a clear distinction between the different type of gliomas that are there. And as you can see, so here zooming in a little again on the difference there with the non-enhancing tumors and the enhancing tumors. So in the non-enhancing end of this, we look, for instance, at the oligodendrogliomas on the left-hand side. The overall prognosis is well around 10 years, but around 14 years. While again, could also be a non-enhancing type of glioma. But then if we look at the tissue and we look at the biopsies and the molecular biomarkers, there is this particular biomarker, which is whether or not there's a mutation in the IDH gene. We see that the glioblastomas, or the very aggressive tumors, come out here as they're very aggressive, and they have a very poor survival, so only about a year. When we look into treatment of these brain tumors, we have, well, of course, several options, and maybe, well, very often the very first stop will be surgery. We do the surgery, of course, because we need the tissue in the end to do a biopsy for the diagnosis. Quite often, this also means that during surgery, patients will undergo maximum safe resection, simply taking as much of the tumor out as possible. And rarely, at least in our center, rarely, but it can happen. That could also be a watch and wait procedure. If it's maybe very clear, or there is a high chance that it's a lower grade tumor, patients might undergo sort of a watch and wait period. Then one of the important aspects will be chemotherapy. So this can either be adjuvant or concomitant, and we have either a combination of different types of chemotherapy, or and also giving temozolomide. So really drug-related treatments. And of course, we also give radiotherapy. So this is a huge variation in different type of schemes that can be given to patients if the diagnosis is glioma. And of course, how you go on these routes and what type of treatments are given will be very, very dependent on the diagnosis that you will, on the diagnosis that is related to the World Health Classification Scheme. And just to highlight, it's really important to make these decisions on a patient-by-patient basis, of course. And this I always like is the guideline on care for brain tumors in our hospital, which really tells you there's a lot of moments that you have to decide, and that there's treatment decisions, and there's a lot of decisions to be made. And well, I wouldn't be speaking to a group of imagers that you know that throughout this entire course, if we're looking at the treatment of these type of patients, imaging is, of course, our cornerstone in following up and knowing what's happening. So not only, of course, as a first stop, so what we want to do is, see if there is a tumor, and then also, importantly, use that information for surgery planning, or of course already to start following up the patient. There will be a scan directly post-surgery to just simply see what is the extent of surgery, how's the patient, how has everything happened, and then that will be quite often, so in our center, a few weeks later, we'll take another MRI scan that is used for radiotherapy planning. And then, of course, this patient will have to go into follow-up and will undergo even more scanning. So a lot of imaging happening there. And then what is happening usually, or quite commonly, is that we use a set of standard or conventional MRI scans. So what you can see here is that in particular in the Dutch national guidelines, but I think still internationally in quite a lot of national guidelines, this takes into account structural scanning. Usually I refer this to as a standard scans, or also often you see as conventional scanning. And I think an interesting aspect here is that even though at the right far end, you see the diffusion, apparent diffusion coefficient or diffusion weighted imaging, which is done already quite a lot, but still not every data set will have this ABC measurement in there, because it's still simply not part of some of the guidelines. And then if we look at the physiological MRI, the scans that we're going to investigate a little bit more during my talk as well, these are even rarer to find regularly happening. And in particular, I always put into brackets advanced, because I also put something on here on the left-hand side as relative cerebral blood volume from dynamic susceptibility contrast scan. So this is certainly a scan that has been available for a long period of time, but again, not necessarily clinically done in every patient. So why then do I think it is important to start addressing the physiological MRI? Well, and I think it's important to realize here that these techniques can give us a lot of extra information. So with these techniques, you can really start to probe the microenvironment of the tumor. And for that, I've used this image with permission from Dr. Zore Amuskar, of which I briefly had a joint presentation with last year. really indicating that the microenvironment of the tumor plays a huge role. And I think I don't have to say this to all of you, in how the tumor fares, how it's, what the pathophysiology is, what the diagnosis and prognosis is. And currently, in vivo biomarkers to assess the microenvironment are quite rare. But what I like, in particular, this group also illustrates that, is that those physiological MRI acquisitions in particular probe different parameters of the microenvironment. And you can actually start to use those parameters to start to assess the microenvironment. And with that, of course, that opens up the potential to address, numerous clinically relevant questions. You can think about aiding accurate diagnosis by doing image-guided biopsies, but also later on in the follow-up of patients when you have to detect progression versus pseudo-progression after treatment, potentially optimizing radiotherapy treatment planning. And of course, having a nice in vivo measurement also aids further understanding of brain tumor pathophysiology. And to come back to the development end of this, well, as I already hinted at, all of these advanced physiological MRI techniques, they're all often referred to as emerging techniques, as they are up and coming, even though they have been around for some time, but they're not yet making it to routine clinical practice. And I think a large part of that is that the development, of course, is required there to think about how should we measure, to validate what we then actually are measuring, and also then to think about, okay, now we have this setup in which we've done everything sort of optimized, and also to validate, how do we actually get this into clinical practice? And Esther also already nicely mentioned that, but that's really what I try to do within my research line, is to be that bridge in which I really cover sort of from development to validation to application, and the other way around as well, if there's a question, a clinical question where we can use new MRI techniques to do this. So ITEM, the project that I want to discuss, is really centered around the bit of development and validation. So that's the bit I'm going to discuss more now. And again, if you have any questions, or if this goes very fast, don't hesitate to interrupt. But I see nothing, so I will go and continue. So ITEM stands for the Imaging for Tumor Environment Mapping Study, and it really combines a little bit of two different projects. And I have two brilliant PhD candidates who are working on this on these projects, and I'm just going to one by one go through them in the following slides, starting with looking at the Making the Invisible project, which focuses around amide proton transfer CEST imaging. So CEST stands for Chemical Exchange Saturation Transfer Imaging. And I know that for some of you, this might be very well known. And this is also a very, very brief introduction to CEST MRI. But basically what we do with this technique is that we use off-resonance frequencies that target protons that are bound to specific, for instance, proteins that we have dissolved in the free water. And because those protons exchange with the free water, we can actually see that signal coming up in our MRI signal. I always like this image, which from the Peter van Zijl review, the paper is great, that also fully explains the technique there fully. But I like this picture often even more, where it's sort of illustrated what you can do with this. So here we see an MRI image of a fresh egg. We see the egg there with the egg yolk and the egg white. Now, what happens if we give an off-resonance frequency, specifically at the frequency that has amide protons, that's at 3.5 ppm. There's a lot of proteins that have those amide protons. And what you can see is there at the bottom that you see in the red line in the egg white, that we see that decrease in saturation in the MRI signal in that Z spectrum on the left-hand side. We can enhance that. So on the right-hand side, we see the MTR asymmetry measurements. And it really tells you that if you want to do any protein buildup, do forget the egg yolk. It has no protein, basically. So why is that important for us? Well, so this particular technique, the APT-weighted CEST imaging, has already frequently been linked to active cell proliferation. So what we see here is an example of a study in which they've looked into, I think, about 30 patients diagnosed with brain tumors, where they have done APT-weighted imaging as well as taken a biopsy and looking at labeling of Ki-67. So this is a marker of active cell proliferation. And what we see here is more and more studies are showing that this APT signal is actually related to the protein buildup with that cell proliferation marker. And with that, for instance, you can already think about that APT-CEST can be useful for glioma grading. Here, an example of how low-grade and high-grade tumors can be differentiated simply because the more aggressive a tumor becomes, the more active cell proliferation is there. So that makes this a really nice new biomarker in brain tumor imaging. So the very first thing that I did when I came to the Erasmus Medical Center was also try and see whether we can adapt this technique or use this technique in non-enhancing glioma. So this was done by a study in the IGENE study that was led by Marion Smits, of course. And we collaborated with this magical, great MR physicist from King's College London, so Tobias Wood, who developed a volumetric APT-weighted CEST acquisition for us. And what you can see here on the left-hand side is that if you use this particular technique in these non-enhancing brain tumors, not only with this acquisition, we could cover the volume, so we could cover the whole tumor, but you can actually start to see that there's quite a heterogeneous level of increased APT-weighted values in these tumors that potentially are just very useful for clinical implication. And I think one of the nice things that the volumetric measurement gave us is that we really can assess the full tumor, and noticing that heterogeneity is also important to think about when you, for instance, have a novel image acquisition. One of the aspects of APT-weighted CEST is that in these new imaging techniques, it's a long and a slower technique. So single slice acquisitions are not necessarily, were the first acquisitions we were taking. But here, this is a nice patient showing that it really depends where in the tumor you take that single slice, whether or not you're going to get meaningful information out of that. So this was really a really first step for us with the application there of APT-weighted CEST as well. And then our PhD candidate, Yulan Wu, he really developed this further, still in collaboration, of course, with Tobias Wood, where we adapted our volumetric acquisition of APT-weighted CEST to match a 3D snapshot CEST acquisition that massively sped up the image acquisition. And this allowed us to generate a more richer pool of CEST data. And Yulan then additionally works on generating a full set of post-processing scripts and pipelines, and ended up illustrating that if we do a Lorentzian difference analysis, a certain type of data analysis approach, we could really neatly use APT-weighted CEST as well, but as well as at the same time generate another contrast NOE-weighted imaging from these techniques. And again, this was a really nice sort of confirmation of works that already are out there that also illustrate that both APT and NOE, this additional parameter you can get from CEST imaging, give you valuable information. So very, very briefly about the development of CEST, of what's been happening so far at the Erasmus Medical Center. The second step was, of course, also looking at cerebral oxygenation. So looking at the microenvironment where we specifically focus on hypoxia and the vasculature. And this is work that has been done by most of the work in this branch of the item study has been done by Fatemeh Sadat Arzan Farouche, or Fatemeh. So the aim of her strand of this project is really to develop and validate that clinically applicable framework to measure oxygen delivery to glioma. And of course, we want to do this with MRI. She does this based on the very simple schematic that we have here of brain tissue, where what we really want to do is assess the amount of oxygen flowing in, which in this particular case we do, of course, with arterial spin labeling, which we use the technique for that. We have a product sequence from the General Electric, so from GE, from the systems that we have. But one of the interesting aspects of this model is that we also want to look at vessel size imaging. And this is really because we know that the vasculature in these type of tumors becomes quite heterogeneous. And we, of course, it is a very important aspect of knowing how oxygen or how well oxygen can be delivered to the tissue if you know the microvasculature, the structure of the microvasculature. So for this, we've also been collaborating a lot with GE. So we use a HAPI acquisition, a hybrid EPI. The nice thing about this acquisition is that it functions a little bit as a normal DSC, an EPI acquisition in which you acquire either a gradient or a spin echo acquisition. But the nice thing is that we can do this now in after one excitation pulse. So basically the advantage is that you can do this DSC-based approach with an injection of gadolinium, contrast, and you have the gradient and spin echo at almost the same time points. And the first thing that Fatime started doing to implement this for us locally is to investigate the leakage correction that is required, and particularly required if you have tumors that have that enhancing area within the tumor. And of course, that enhancing area is related to the disrupted blood-brain barrier. And if you then have contrast agent leaking out, so rather than the ideal situation, as depicted here in the dynamics of this in the green line, where you see a contrast agent simply passing through the vasculature, you actually see, because of the contrast leaking out, that the tail of this signal becomes either decreased or artificially decreased or increased. And this then in turn will under or overestimate the relative cerebral blood volume. This is of course something that for those of you in the realm of DSC imaging is well known, that requires correction in your post-processing. So what Fatime did in a really nice collaboration with the group of Michael Chappell, so Professor Michael Chappell at Nottingham University, is investigate also in our local data set whether or not leakage correction is an important aspect. And of course, we know it's an important aspect in enhancing glioma, but also what the effect is on the non-enhancing end of the tumor. So the areas that you don't necessarily have the leakage yet. And I think an important aspect that she found is that in every area, so both in the enhancing and in the non-enhancing areas, applying leakage correction was actually giving us an effect. But in the non-enhancing areas, so what you can see here are sort of the group averages on the left-hand side. And in particular, in the non-enhancing gliomas, this effect was really marginal, and we didn't necessarily see any sort of change in the diagnostic performance, whether or not you would include this. Maybe in hindsight, a little bit as expected, but I think it was still a nice confirmation of that aspect. And of course, because we are now interested in assessing the vessel size imaging, so the microvasculature, for which we need both the information on the gradient and the spin echo, part of her work here in the extension was to investigate what's the leakage correction, how important is it to do leakage correction for vessel size imaging. And for this, she's been working with the first bit of the item patients as well. And we basically, on the left-hand side, you see an example of the same result as for the rCBV. So that it indeed is important to include. So if you look at the averages, the group averages signal on the top for the vessel size images, that you do see an effect on all ends, so whether it's in a healthy tissue or in a non-enhancing tumor. But again, the effects are very, very small in the non-enhancing areas. And with her sort of completing then the post-processing pipeline for this work, I think one of the nice things that she's been working on to illustrate the added value of looking at the vessel size imaging as well, so looking at this novel imaging biomarker, she has been looking into a patient cohort of 38 patients with a non-enhancing glioma again. So as a reminder, there's no tissue that is enhancing, so no blood-brain barrier breakdown. With this pipeline to assess rCBV and VSI. So that means that all of these patients undergo MRI scanning, and that during this MRI scan, so sort of at the very end, we take that hybrid EPI acquisition to assess the VSI parameter. And I think the interesting bit of the results that you can see here is that she is finding, as expected, on the left-hand side, the changes or the significant differences between the oligodendroglioma and the astrocytomas, indicating that the rCBV is highest for the oligodendroglioma. So this is a type of brain tumor that is generally the most benign form to have, the lowest grade. While in the astrocytomas, you actually see a lower rCBV, and there is actually a trend for an even further increased rCBV for the glioblastoma patients. And on the vessel size end, we see sort of a different, the same pattern arising, but then inverse, where we have smallest vessels in the oligodendroglioma, the highest in the astrocytomas, and then more or less an intermediate version in the glioblastomas. And I think one thing that is very nice about this work is illustrating that by combining these two techniques, both rCBV and VSI, you can actually start to probe the microvascular structure of these tumors, which is actually in line with what we know from the literature, what's happening in these type of tumors. So for instance, what we know is that the oligodendrogliomas, even though that they're the lower grade and give you a very benign, a very long overall survival, they have this chicken wire vasculature that actually does give you a very high rCBV, and then potentially a low VSI. And so that's that difference between the oligodendrogliomas and astrocytomas might be something that's really actually there and giving you a little bit more insight about what's happening locally in the vasculature. For the glioblastomas, we saw that intermediate rCBV and a high VSI, but I do have to note here that in this patient group, we only had 7 IDH wild type glioma. So it's all very small numbers, and certainly on the highest grade, we don't have a huge group of patients here. But as I mentioned, I think it's a really nice way of illustrating how with this addition of VSI, you can really start to probe the microvasculature non-invasively as well, which of course may aid then pre-surgery diagnosis, but also potentially the follow-up of these patients. Do I still have everyone? And again, don't hesitate to interrupt her if you have any questions. So the second bit, the second technique that Fatima has been working on to develop is looking at the oxygen extraction fraction. Because of course, if we want to start probing the oxygen metabolism, it is very important to actually assess how much oxygen is actually being delivered or taken out, used by the tissue. And for this, we have been investigating a quantitative BOLD technique. And this is an approach in which we quantify R2 prime. So we actually start to quantify how much effect of the field, trying to probe whether we can assess how much deoxygenated hemoglobin is actually locally present by assessing the magnetic field perturbations there. Now, we're certainly not the first group who have been doing this. So again, the Stadelbauer group I mentioned before, they have a really nice way of using estimating first R2 and then R2 star separately to probe that R2 prime measurement. And from that measurement, from both those individual measurements, you can get a map of the oxygen extraction fraction. So here, also in collaboration with Dr. Alan Stone and Nicholas Blockley, we are actually trying, we have implemented the asymmetric spin echo acquisition. And this is something that is an approach in which with the asymmetric spin echo technique, we can estimate R2 prime directly. So we don't have to, again, do a registration between the R2 map and the R2 star map of 2 separate acquisitions that estimate those parameters. And another nice thing is that in this model, immediately you can also actually get an estimate of your deoxygenated blood volume. And with this approach, already back in Oxford, Alan and Nick showed that you can actually use this in glioma patients to start to probe that those parameters as well, and start to probe oxygen extraction fraction within these group of patients. And again, so what we had to do first is ensure that we got our local implementation of that system. So this acquisition. So again, I hope that I'm speaking to an audience that is fully aware how if you take a novel image acquisition if you want to look at a novel image acquisition that is not necessarily a product acquisition, it requires a lot of local implementation. And for that, Fatime has initially started with looking at healthy volunteers and seeing whether we can use this quantitative BOLD to actually probe changes in functional MRI values that we would be seeing. So what she did was a study in which we included 8 healthy volunteers. One of the nice things here I have to mention is that we did this in collaboration with Avery Berman as well. He's at Carleton University now in Canada. And he helped us really in setting up this acquisition locally. So these 8 healthy volunteers, they underwent structural scans, but also, of course, a baseline and a stimulus scan. Of course, with the idea to probe what is happening in the visual cortex if you're looking at a visual stimulus. And what we see here, so this is a group average result of mapping then the R2 prime, the deoxygenated blood volume, and from that, of course, model the oxygen extraction fraction, is that first of all, we see results reflecting really that functional hyperemia. If there's if the visual cortex becomes active, there is actually more oxygen, the blood flow is actually increasing so much so that there is more oxygenated blood locally, and we see this decrease in R2 prime. I do also, again, already have to mention what I also have to mention. You don't see significant results here everywhere because, of course, this technique is a low in signal to noise ratio, and which is something that we really have to probe and have to start to investigate as well, in particular when we then look at the patient data. So this is the first patient that Fatime scanned, in which we see a glioblastoma at the location of the red arrow. And I think the neat thing is that indeed we were able to investigate or illustrate that we saw this heterogeneous pattern as Alan and Nick also did in Oxford. But it's also certainly an area that's heterogeneous in the cuboid biomarkers. And of course, a large chunk of the work that we're doing now is to validate what we actually are seeing in this particular study, or in these particular results. So far about the development. I'm also having a look at the time. Okay, so very, very quickly, it's the Q2 I see. So very, very quickly, what I wanted to illustrate is that in item, what we're doing now in order to start to understand what do we see in the cuboid, what do we see in the CEST, what we really want to do is validate. So what we're doing is scanning patients. We scan the patients the day before they undergo surgery, and then we look at targeted biopsies in the lab. We do this again also in collaboration with King's College London. So here we see Tobias Wood as well as Thomas Booth, is the neuroradiologist there. And here we take these patients, we recruit patients that have primary brain tumors and that are of course planned for biopsy or resection surgery. We do the whole lot. So we do a scan that contains perfusion, but also CEST and the cuboid. We also do the VSI imaging. And then what we then do is aim to validate these techniques where we really want to look at APT-weighted imaging and see on the protein level whether we can actually match what we know, what we hypothesize is happening locally with this increase in protein content, whether that's actually happening. And on the VSI-weighted and VSI imaging and the oxygen extraction fraction, we're doing a similar approach, but then with immunohistochemistry. And these are simply some very, very preliminary results of that work. So this is where Yulan with his student is looking at APT-weighted CEST MRI and proteomics. What we see is that in each of these samples that we take from a patient, we can identify sometimes even well over 500 proteins per biopsy accurately. So that gives us a whole range of proteins to look at. And we're trying, we've been generating a pipeline to first of all look at, can we even assess the total amount of amides locally? Very simply because that's of course the parameter that we are supposedly sensitive to with CEST MRI. Interestingly, in the very first patients that we're seeing, so here we have analyzed data of 4 patients, we actually see a negative trend in all of these, in the correlation between APT-weighted CEST and the amide count. And of course, this is very much a work in progress. And to be honest, I would love to have any of your input as well, if you have some ideas potentially already as to what we're seeing here. But of course, this is for us still a very much a research question. Are we looking at the right amides? Maybe we're not looking at the most appropriate CEST metric. So very much open to suggestions there. And for the VSI and the OEF, this is the work that Fatima has been doing together with Maaike. Similar pipeline, but here, of course, we're looking at histopathology. So we have stainings of the amount of cells simply present. So that's the H&E staining of hypoxia, the HIF1 alpha, and CD31. So that's the measure of the vasculature. And again, for each patient, we have this at different locations. So we're getting quite a lot of data that also requires a lot of image analysis that to me was, of course, very, very new. And it turns out that for our pathology lab, it was also not necessarily that straightforward to actually look at quantification of these images. So we've spent the last year working out on how to actually quantify these types of images. And I think Maaike has done a really good job at making sure that from the CD31, we can actually get parameters of diameter and density. So that's an example of the high vascular area on the left-hand side. And on the hypoxic areas, we get measures of how hypoxic the tissue is based on the HIF1 alpha stainings. And again, just to illustrate some preliminary results, these are results from 2 different patients, one oligodendroglioma, one astrocytoma. On the left-hand side, we start to see something that is a correlation between VSI and the mean vessel size of the tissue, which we know should be happening. This is previous work that has done this. So we're really, again, trying to sort of reproduce their results. Hopefully this will last if we have more patients. But if we look at the oxygen levels, one of the interesting bits is, so at the top you see the patients combined, the oxygen extraction fraction measured or correlated with the H scores. And you actually see sort of 2 very different pictures in these 2 patients. So again, very much for us, a search in how our data is going to progress, but also are we looking at the right ways of correlating these techniques? So another work in progress. And that was really about the item study. The very end, I wanted to give you a very brief example, and I'm going to look at the time, noting that I might be okay for continuing. Yeah, go ahead. Yeah. How, if we do all this, we have all this development and validation going on. We have biomarkers that we are trusting and that we can use for future work. What can we do with them? And for this, I wanted to highlight the project of Patrick Tong, who is looking into now bridging advanced imaging and radiotherapy planning. So very, very briefly, if patients go and have radiotherapy, so these are usually we're focusing here on patients with glioblastomas, so the highest grade brain tumor. There was a lot of drawing of target volumes. Where are we going to give the radiation dose? So here we have, we start off with illustrating where is the macroscopic tumor based on structural scans, of course, the T1 weighted post-contrast scan, T2 weighted scan. And to account for microscopic invasion, we simply do an expansion of those volumes. We take into account certain aspects that are anatomical, but we don't actually measure microscopic invasion. And what that means actually is that the clinical target volume, so the volume of tissue that is actually receiving dose, will include a lot of healthy tissue. And it also means that there is a lot of radiation toxicity. So there's additional necrosis, cognitive impairment, and which indeed can really be a big burden for the patient. So really reduce the quality of life. And what Patrick has been doing first is trying to investigate, can we now use these parameters to look at microscopic tumor invasion and better generate a target volume for these patients to be treated? And really go from that clinical target volume that is based on structure to a biological target volume. And in his master's thesis or in his master's work, what he's done is generate algorithms that would automatically generate that biological CTV based on those advanced biomarkers rather than the conventional CTV. And what we see is if we use that information, we can actually reduce the volume of the radiotherapy target quite a lot. And interestingly, for 3 out of 4 patients, what you're seeing here is the percentage of overlap where later on for these patients, a recurrent volume occurred. So basically, where later on the tumor did appear. And we actually saw very, very low values. What basically means that for those 3 out of 4 patients, a large reduction of the target volume was actually feasible for radiation therapy. And potentially, we're not actually risking a lot of making the recurrent disease worse or clinically a lot worse. And that's really led to, so this thesis work has really led to the start of his PhD. He started his PhD last week only, where he's going to look into that, into the treatment follow-up of the patients, in particular, making sure that we scan them at the right time. So in ITEM, we've scanned all these patients just before they undergo surgery, but of course we want to scan them before they undergo radiotherapy. And this work is really just started. So we're currently scanning, I think the first patient is planned for this scan next week. So really hot off the press, no preliminary results so far. And then the very final 2 minutes, I wanted to very briefly introduce you to Glimmer. And I think by now, hopefully you've already realized that I think collaborations are not only important, but they're also really needed for this work. And with Glimmer, we really bring all of that together. Glimmer is a European network. It's funded by COST, so that's also European. It's EU-funded networks where we aim to bring everybody together. So not only us researchers, but also the clinicians, industries, and patients. We are a relatively young network, so we started in the 12th of September 2019. And we really aim to sort of foster a lasting network to further glioma imaging diagnostics. So you can find a lot of information about us also on our website, glimmer.eu. But by now we have grown to approximately 200 members from mostly European countries, I do have to say, because of course our funding is based on bringing people together, but you have to be affiliated to a European institute to make use of this fund. We then have networking tools, so we generate meetings, we have training schools. We had a really nice training school on AI and neuro-oncology in July, and we're having our next annual meeting in Turkey. So hopefully some social distancing there, which I was discussing with Esther just now. We organize webinars. We collaborate with brain tumor, but also with patient organizations. This is a really nice example of how we made a patient information video about data sharing in this day and age that we have to really think about data protection and your privacy. This video is available in 17 languages. We released it in November last year. We did that together with the International Brain Tumor Alliance. It was a really nice experience. And we really also bring people together to further imaging or glioma imaging diagnostics. So that's a nice example of that is the MAGMA special issue. So there is about 15 papers from our network brought together in the special issue that we published in January. But we're also providing position statements on how far along we think advanced imaging techniques now are to actually aid glioma imaging diagnostics. So in summary, I hope I've showed you in the past hour that with advancing physiological MRI acquisitions, you can really start to improve glioma imaging diagnostics by probing the microenvironment. It can potentially lead to solving clinically relevant problems. As an example, of course, the reduction of target volume in radiotherapy, but that I really truly believe that we will not be able to get there if we do not work together locally, nationally, internationally, which is why I'm very, very grateful for this opportunity to kickstart your webinar series. And I'm very happy also to have questions, discussions, hopefully continued discussions later on as well, even after the webinar. Thank you very much.
Thank you very much, Dr. Warnert, for this really great talk. We already have some questions, but I want to just remind other audience, please address your questions with Q&A box or by raising your hands. I think we can, let me just give the microphone.
Oh, yeah.
To Chris Farrar, and he is already promoted. So Chris, if you can just unmute yourself, please just. You can
unmuted now. Can you hear me?
That's perfect.
Okay. Hi, yeah, great talk. I do CEST imaging myself, and I mean, one thing about APT, you saw that weird correlation with protein concentration. I mean, at least in a lot of my studies, I mean, we don't really see elevated protein concentrations. And you know, the APT is kind of a mixed contrast. You have all these contributions, not only from amide, but the NOE, the MT, even water T1 and T2.
Yeah.
So it's not always going to correlate with protein concentration, I think.
No. I would certainly agree.
So I'm wondering, have you looked at, you showed some Lorentzian fitting. Have you tried looking at that? You know, I know Greg Stanitz has done a lot of stuff, and in his studies, usually actually he sees a decreased amide contrast
exactly.
from Lorentzian fitting.
Yeah, so no, what's one of the things that, and I also have to think whether Greg also uses to T1. You're certainly right. The CEST signal that we're getting
sometimes as well.
Yeah, exactly. And so one of the things that I think we truly missed out on in our imaging protocols that we didn't include for these data sets, we didn't include actually mapping of T1, because I think that will also hugely affect what you actually see with your APT, which APT metric you're going to use. So what's part of the work that is happening now is indeed investigating whether we're using the right metric even on the APT weighted side, because it's so difficult also for us. So we're using a Lorentzian fitting. We now have due to the snapshot acquisition, we acquire 54 offsets. So in that sense, we do actually get quite a nice data sets, and we also have it with 2 different B1 powers. So there we also really try to do some corrections for B1, for instance. And we're really still investigating whether this is the right approach. And I think one of the nice examples is that I think it will be very, very difficult to indeed really match it to protein content. But what we're also doing with our proteomics lab is trying to assess whether it's more the metabolic profiles. So in the molecular pathways that we get from the proteomics, whether that's even more reflective of sort of what's happening there, if that makes sense.
Yeah,
I don't know whether that fully answers your question.
Great, thank you, Chris. We have another question from Miriam. So if you can unmute yourself, please.
Yes, hi, thank you. My question is regarding leakage correction methods, and I wonder how sensitive these can be. I'm interested in looking at blood-brain barrier disruption, but is very subtle, such as not like a mild traumatic brain injury or focal epilepsies, for example.
Well, this is a really good question, and maybe I am going to ask you, maybe I will also ask you later on to discuss this further, because I've recently got this question from our stroke center as well, whether we can, and even in mild injury, can look at this. One thing, so I have to say that we haven't looked into that fully, but because we recently had that question from our stroke collaborators, we started looking into whether we could use, in particular, so Fatime also tried out she developed the bidirectional model as well. So we then get the parameters, basically the permeability parameters from both of those models, and seeing whether we can probe those to also in that non-enhancing area, simply because we did see that we could see the effects in our healthy tissue when we were looking at the brain tumor data. And I don't know what your experience is, but in general, what's our first go at trying that out was that with the leakage, like with the parameters, so the exchange rate. I'm taking CEST info, but how do we call it? The coefficients that we get out of the leakage correction algorithms, they weren't necessarily that sensitive in healthy tissue to be very promising for us to really quantify them. But I would love to hear your experience about that, actually.
Yeah, so I mean, there are some works, and that was described using gadolinium leakage by looking at slow blood-to-brain barrier disruption, and that's work from the team from Dr. Friedman, where they look at extended durations of dynamic contrast enhancing MRI, and other groups who work on also on people with dementia, so it's aging brain. So I mean, I'm happy to discuss this offline at another occasion too, and see if this should be considered.
Yeah, no, I would agree. Yeah.
Thank you.
We are just on the mark of our time, so it is very timely. Thank you very much again, Dr. Warnert, and thank you for everyone who joined today. See you next week.